Bismillah ar-Rahman ar-Rahim. This is the second part of the lecture for anesthesia for right side obstructive lesions. After talking about the fellow, we'll talk about my pulmonary stenosis. Pulmonary stenosis is either valvular, sometimes associated with Noonan syndrome, sometimes subvalvular, infundibular, or subinfundibular, double chamber RV, supravalvular, like congenital rubella, and syndromes like Williams syndrome, Noonan, Alagille, Leopard syndrome. The Noonan syndrome has cardiac and non-cardiac anomalies. Dysplastic pulmonary valve, Hocum, and the non-cardiac are short stature and facies. Leopard syndrome is supravalvular aortic and pulmonary stenosis, short, ill-fine, impaired cognition, endocrine and genitourinary abnormalities. Williams-Byrne, supravalvular aortic and pulmonary stenosis, ECG abnormalities, facies, deafness, genitalia, retarded growth. DeGeorge syndrome, we said it in the previous lecture. Alagille, peripheral pulmonary stenosis, facies, cholestasis, butterfly vertebrae, Cutal, peripheral pulmonary stenosis, abnormal cartilage calcification, deafness, congenital rubella, peripheral pulmonary stenosis, open duct Botali, cataract, glaucoma, retinopathies, and deafness. Okay, preoperative, we ask about age and weight. Symptoms increase with age because the patient gets larger with a fixed stenosis. Baseline saturation, maybe cyanotic if there is shunt like ASD, PDA, or VSD. History of low cardiac output, congestive heart failure, failure to thrive. Severity depends on the gradient across the RVUT, the presence of a dynamic obstruction at the infundibulum, and the presence of other sources of pulmonary perfusion. So if the gradient is high, and there is a severe stenosis, but with another source of pulmonary perfusion, so the patient would be less symptomatic. ECG, right axis deviation, P pulmonale, RVH and RV strain, chest X-ray cardiomegaly. Critical PS is defined as severe PS with an ASD or a PDE causing right to left shunting, cyanosis, and heart failure. So this is the critical PS. Surgically, management, first balloon pulmonary valvuloplasty in the cath lab if the gradient till the gradient is less than 30. Otherwise, surgically, if the annulus is hypoplastic, pulmonary valve is severely dysplastic, or other anomalies, either we repair the pulmonary, dilate the pulmonary with a dilator, we put an RVOT patch, pulmonary artery repair, transannular patch if the pulmonary valve is unrepairable, conduit if a coronary passes anterior to the RVOT. If the valve is replaced, mechanical valves are avoided due to high risk of thrombosis. In critical PS, urgent intervention is needed, like balloon pulmonary valvuloplasty, PDA stenting, or surgery. Either to repair of the pulmonary valve in the neonatal period or early in infancy, or an MBT shunt. This is a transcatheter pulmonary valve implantation. It is one of the management solutions, but in larger patients. It's similar to the TAVI, but on the right side. Complications of balloon pulmonary valvuloplasty. Transient bradycardia and hypotension during balloon inflation, because during inflation the cardiac output falls. You interrupt the blood flow, So practically a circulatory arrest occurs, but only for a few seconds. So usually nothing happens. Nothing dangerous happens. But you have to keep in mind that the right ventricle of these patients may be in a lot of strain, and may be ischemic with high demand. So even a transient or even few seconds of cardiac arrest or circulatory arrest may cause severe stunning, or may descend into a complete real cardiac arrest requiring CPR. Transient permanent AV block, tricuspid papillary muscle rupture, which is a surgical emergency because the patient will not tolerate acute severe tricuspid regurg. Pulmonary artery rupture, causing pericardial effusion. RVOT obstruction due to infundibular hypertrophy, because if you open pulmonary stenosis associated with an infundibular stenosis, subvalvular pulmonary stenosis, so if you relieve the stenosis, the valvular pulmonary stenosis, that is the afterload faced by the infundibular stenosis, so the infundibular may collapse. Sometimes they call this situation suicidal RV, so that the right ventricle or the infundibulum would get into spasm or would contract or would collapse upon itself, interrupting the circulation. Reperfusion injury may occur, may require high PEEP. Pulmonary incompetence may tolerate some residual PS to prevent severe pulmonary incompetence, but mild to moderate is acceptable. Intraoperative hemodynamic goals are preload, maintain good preload because of the stiffness of the RV, unless there is congestive heart failure, so we use diuretics. Maintain normal heart rate, normal heart rhythm, maintain good inotropic support in congestive heart failure, avoid increase in pulmonary vascular resistance, be very careful with inhalation induction. Sometimes these patients are also, like the fellow, are preferred to be anesthetized by IM ketamine. TE check gradient across the RVOT. Pulmonary valve may be thick, dysplastic, or bicuspid. Decide whether the valve is repairable or not. RV hypertrophy, RV function, tricuspid regurg, and other anomalies. This is a supravalvular stenosis. There is a ridge here, or narrowing just above the valve. This is also a supravalvular stenosis. This is a valvular stenosis, and the pulmonary valve doesn't look good. The annulus is narrow. And the leaflets are not thickened, but they appear to be fused or bicuspid, so the entire RVOT is narrow. This is an infundibular stenosis. Dazing starts from here, from the RVOT, and then increases at the valve. Post bypass, check the saturation, check the RV pressure by TE, RVOT gradient, and by direct needle measurement. The RV pressure should be less than 2/3 of the LV pressure, or the aortic pressure. Usually need inotropes and good filling. The RV dysfunction is more expected if ventriculotomy was done. Inodilators may be added, unless there is infundibular stenosis, so I avoid inotropes altogether. Pulmonary insufficiency is usually tolerated, but not severe pulmonary insufficiency. Anyway, even if the patient can tolerate severe pulmonary regurg or free pulmonary regurg, like in cases of transannular patch, but he will not tolerate it for life. After some years, he may come back with right-sided dilatation, and he may need this pulmonary regurg to be corrected either by surgical repair or transcatheter pulmonary valve implantation or whatever. TE post, we check the gradient, the RV function, and there would be a free regurg in transannular patch. Okay, pulmonary atresia with intact ventricular septum. We check the age and weight of the patient, the saturation. This is a case of total mixing, so the best saturation is 85 because this is the average between the venous return of the coming from the lungs, which is 100%, and the venous return coming from the body, the vena cava, which is should be around 70%. So if the cardiac output, the QPQS, are equal, so the venous return would be equal on both sides. So the average between the pulmonary and systemic venous return should be the average between 170%. So 85 is a sign of a QPQS around 1 to 1. History of low cardiac output, failure to thrive, signs of myocardial ischemia may be associated with tricuspid valve, RV, or coronary anomalies. There is always an ASD or a PFO and a PDE that may be restrictive, which is a neonatal emergency, especially with a closing PDE, because this is the only outlet for the right side. So there must be an ASD, a PFO, a PDE, or a VSD. High RV pressure may cause sinusoids. These sinusoids occur when there is a pulmonary atresia with an intact interventricular septum and no tricuspid regurg. So the blood goes into the right ventricle and is trapped. So it gets trapped until the pressure rises greatly. So this high RV pressure may dilate the veins draining into the Thebesian veins draining from the myocardium into the cavity of the right ventricle, causing sinusoids. And by time these sinusoids become the blood flow of the sinusoids may perfuse part of the myocardium together with the normal coronary supply from the coronaries. So the myocardium of the right ventricle becomes dependent on a high RV pressure and the blood coming from the sinusoids. In some cases, the flow in the coronaries is reversed through coronary fistula, and a large part of the myocardium is supplied by deoxygenated blood and is ischemic. This is called RV-dependent coronary circulation. Cardiac catheterization is essential to determine the presence of sinusoids and coronary fistula. This is a ventriculogram for the right ventricle. This is the catheter. They injected the contrast here, and the sinusoids appear here. These are the sinusoids. And if you notice, the contrast filled the sinusoids, and then they are filling the coronaries, retrograde. These are the coronaries. So the blood supply of the coronaries is dependent partially on the high RV pressure. The LV is usually dilated. The IVC may compress the LVOT, causing obstruction of the LVOT. The patient sometimes needs urgent Rashkin procedure, PDA stenting, or is started on prostaglandin. Usually needs a CT scan to check the anatomy of the aorta, the great vessels, pulmonary arteries, coronaries, PDs, and MACs. Hemoglobin level and hematocrit, polycythemia, history of embolism, either thromboembolism or paradoxical embolism. This is another image of the sinusoids. So the sinusoids, they fill the coronaries. Surgically, sometimes the pulmonary valve has normal size and anatomy, but with fused cusps. So if the patient is lucky, the repair is possible. Otherwise, transannular patch may be needed. Pulmonary arteries are usually of good size due to the PDE, but may be small. If the RV cavity is small, so a Glenn shunt may be needed, or a 1.5 repair is done. Catheter-based pulmonary valve perforation and balloon valvuloplasty are sometimes possible, but with a risk of pulmonary artery rupture or perforation with effusion, pericardial effusion. Rashkin PDA stenting empty shunt may urgently be needed after birth. If significant sinusoids are present, the RV decompression is avoided, and an MBT shunt is needed. So we cannot decompress the right ventricle in these cases, and we cannot repair the pulmonary atresia even if the valve is repairable, because this would decrease the RV pressure and would render the myocardium ischemic. So we can't do that. Another problem is when going on bypass, the entire heart is decompressed. So during bypass, the right ventricle may become ischemic, and the patient may have a myocardial infarction on bypass. So there are two solutions: either to pressurize the RV during bypass. We either insert an arterial side branch from the arterial cannula to pass through the tricuspid valve to the RV. So the bypass machine would perfuse the arterial system, the aorta, and the right ventricle at the same time. So this would pressurize the RV and prevent myocardial ischemia. Or the surgery is done without full cardiopulmonary bypass. So we go on half flow or something to keep the blood flowing into the heart, into the right side, to prevent RV decompression. In the presence of multiple MAPCAs, unifocalization may be done. Unifocalization is a procedure in which this is a collateral. This is a collateral, and this is also a collateral coming out of the aorta and perfusing the lung, and this is the pulmonary atresia. So we correct the pulmonary stenosis. Here they are putting a valve, and then we dislodge the collaterals from the aorta or its branches, and connect them to the pulmonary arteries. So this is the left collateral. We take it from here and connect it to the LPA, and this is the right side one connected to the RPA. This is called unifocalization. Sometimes, if there is absent pulmonary artery, we take these branches and connect them directly to the stump of the pulmonary artery here. This is called unifocalization. Keep hemodynamic goals. Maintain preload, maintain normal rate, normal rhythm. The RV may need inodilators and may be ischemic. High systemic vascular resistance by vasopressors. Lung perfusion is dependent on mean arterial blood pressure either through MAPCAs or PDE. Low pulmonary vascular resistance, so increase FiO2, decrease PCO2, and avoid acidosis. Avoid anemia to maintain oxygen content more than aerobic threshold. If the patient develops pulmonary hypertension, increase FiO2, decrease PCO2, avoid acidosis, good anesthesia, avoid hypoglycemia, avoid hypothermia or any source of stress, inodilators and pulmonary vasodilators like sildenafil and nitric oxide inhalation. Post-operatively, the lungs may get congested. We should balance the systemic and pulmonary vascular resistance. RV decompression is in presence of sinusoids and coronary fistulae, may cause coronary steal and global ischemia. In cases with transannular patch and free pulmonary regurg with a coronary fistula and an MPT shunt, a circular shunt may occur. This also occurs in pulmonary regurg, tricuspid regurg, ASD, PDA, or MPT shunt. This decreases systemic cardiac output, so the blood flows from the pulmonary artery to the right ventricle, and then the tricuspid regurg to the right atrium, and then through the ASD, and then to the aorta, and then from the aorta to the PDA and back to the pulmonaries. So a circular shunt occurs, which is it decreases the cardiac output to the body. Heparin and aspirin are needed to keep the MPT shunt open without clots or thrombosis. And lastly, we'll talk about the Epstein anomaly. The Epstein anomaly consists of it is an autosomal dominant with variable penetrance. There is an apical displacement of the septal and posterior leaflets of the tricuspid valve. So part of the RV becomes atrialized, that is, it becomes thin and similar to the atrium with thin wall. And this thinning is due to lack of high RV pressure during systole, because this part of RV becomes essentially part of the right atrium. So with the low CV, the central venous pressures, the muscles waste away and become thin. An atrialized portion of the RV between the tricuspid annulus and the attachment of the posterior and septal leaflets. So these are the positions of the anomalous leaflets according to the severity. The more towards the infundibulum, the more severe the case. This is the atrialized part of the RV. So this is the normal part with the normal thickness, but this part is thin because it's essentially part of the right atrium, and the right ventricular cavity becomes small. The anterior leaflet is usually large and redundant like a sail. So the posterior and septal leaflets are apically displaced, and sometimes they are small, and the anterior leaflet is large like a sail. Malformed small RV chamber formed by the trabecular portion only. Most cases have an ASD or a PFO, and they would decompress the right side if it fails. The LV shape may be distorted by the bulging interventricular septum towards the right, causing malfunction and mitral valve prolapse. May be associated with LV non-compaction, which is an anomaly in the anatomy or the histology of the myocardium, causing much trabeculations and arrhythmias and decreasing function. With severe prenatal tricuspid regurg and the RVUT may become underdeveloped with pulmonary stenosis, small pulmonary arteries, and even pulmonary atresia. This is another image of the Epstein anomaly. The leaflets are apically displaced, and this is the atrialized RV. You will notice that there is a large distance between the attachment of the mitral valve and the tricuspid valve. This distance is normally no more than 1 centimeter. So more than 1 centimeter is a diagnosis of Epstein anomaly. If less than 1 centimeter or there is no distance between them, this is pathognomonic in canal cases, in AV canal cases. We preoperatively check the age and weight, baseline saturation, history of low cardiac output, congestive heart failure, and failure to thrive. Severity varies with intrauterine death to being asymptomatic. It depends on degree of effective tricuspid valve orifice displacement, degree of tricuspid regurg, RV function, size of the ASD and PFO, and the shunt across. Paradoxical emboli, arrhythmias, atrial arrhythmias due to the large right atrium, conduction abnormalities due to tricuspid valve annular displacement, Wolff-Parkinson-White syndrome, ventricular arrhythmias with atrialized right ventricle, from the atrialized right ventricle, sudden cardiac death. Surgically, according to severity, either two ventricle repair if the RV cavity is large enough, 1.5 ventricle repair if the right ventricle is borderline, so we can repair the tricuspid valve and then deviate some of the venous return to the pulmonary artery directly through a Glenn shunt. So some of the venous return of the superior vena cava falls into the pulmonary circulation, and the blood coming from the inferior vena cava goes into the heart and passes to the right ventricle and the pulmonary artery. So this is called 1.5 repair. Or a single ventricle repair, Glenn then Fontaine shunt. Valvuloplasty, relocation of the leaflets to the true annulus with or without an annuloplasty, and plication of the atrialized right ventricle. Sometimes the cone technique is used. We benefit from the sail-like anterior leaflet to form a cone-shaped tricuspid valve. So the tricuspid valve become a unicusped valve, single-cusped circular valve with an orifice like a cone. We detach the leaflets from their insertion into the right ventricle, and then we take this large anterior leaflet and we shape it into a cone. And we take sutures here, we shape it into a cone, and then we do an annuloplasty, and we connect this cone to the annuloplasty, and then we buckle and we plicate the atrialized portion of the right ventricle, because this atrialized portion is a weak spot. It may cause an aneurysm or rupture or whatever. So we plicate this part. In older patients, a prosthetic tricuspid valve replacement is better. In small RV, post repair may require 1.5 repair using a Glenn shunt. Electrophysiological ablation for arrhythmias. Intraoperative, maintain adequate preload, maintain high normal rate, avoid bradycardia, maintain sinus rhythm. The RV may need inodilators, may consider prophylactic IV amiodarone or lidocaine. TE post, residual tricuspid regurg, gradient across the tricuspid valve, RV function and filling, residual ASD. Post-operative, the RV plication may compromise the right coronary, so we should check the function of the right ventricle and the posterior region of the left ventricle. Conduction abnormalities, jet is common. Ventricular arrhythmias are common. RV support with introops. The RV is usually small with poor compliance, so monitor good preload without overfilling. The CVP is a good monitor for the right side, and we may tolerate some hypotension, but to avoid the RV failure. Thank you.